So melanoma has a very complex genetic landscape. Although you can have simple activating mutations like V600E BRAF mutations that are important in the biology of the tumor, the melanoma is probably not driven simply by only that or only by simple translocations. Melanoma has a lot of chromosomal aberrations, including losses of parts of chromosome 6, 8, 9, 10, or gains of chromosomes as well. And interestingly enough, because of this complex genetic landscape of melanoma, we're able to use that as a diagnostic test. And sort of this is a schematic of comparative genomic hybridization, or CGH. And what you do is you take the patient's DNA and you mix it with some reference DNA, and where you see a lot more green signals here, that means there's chromosomal gains. And if you see red signals, that means there's chromosomal losses. And we can use this as a diagnostic test because melanocytic nevi tend not to have all these numerous chromosomal gains and losses. However, comparative genomic hybridization is not widely available. It takes weeks to perform. It's very expensive, may not be covered by insurance. And sort of technical limitations, it requires a pretty high percentage of tumor cells for this test to actually work. You need 30 to 50% of the tumor cells, pure population tumor cells, in order for this assay to be effective. So it's not good for small amounts of tumors, thin tumors, or really heavily inflamed tumors, which we sometimes see in melanoma. Now, the folks at UCSF with Padram Garami, who's now at Northwestern, took advantage of this sort of CGH data, and they said, well, let's look at this a different way, and let's do fluorescent in situ hybridization, in which we look at probes that tag the chromosomes. And a rather complex algorithm developed out of this 4-probe set, where they had to have like 38% positive nuclei with greater than 2 signals for 11q, greater than 55 for 6p, and so forth. And at least on their validation set, they had a really good sensitivity, close to 90%, and a specificity close to 95%. And of course, any validation set typically looks at, not the ambiguous lesions that we want this test to perform well in. And sort of following up a different study, they looked at 64 atypical Spitz tumors, and with uneventful follow-up compared with 11 with aggressive clinical course and analyzed by FISH, and they found homozygous 9p21 deletion in the patients that had an aggressive clinical course. And this corresponds to the locus of p16. Like Jen was talking about, when we look for immunostains for p16, if you see loss of the expression of that marker, that's worrisome that they might have homozygous deletion of 9p21, and it may be a Spitzoid melanoma. And similarly, if they have gains in the MYC, if there's amplification of the MYC gene, that's also associated with aggressive clinical course in melanoma. So now we actually use a 6-probe set, combining the original 4-probe set in addition to 9p21 and 8q24 for the MYC gene. And however, FISH is still technically challenging. And I'll show you an example of why. One, expensive equipment, still very difficult in thin melanomas because you need to see a large number of cells to be able to count this accurately. Limited availability. And in terms of its diagnostic performance, at least in ambiguous tumors, it probably has a diagnostic performance of about 70%. Probably better than immunostains, but it's still by no means perfect. And specificity is probably around the order of 80%. So not as good as the validation set, but still pretty good test. There are special issues in Spitz tumors. They frequently are tetraploid. So here's an example of a normal FISH. If you look at this, pretty much all we're looking at counting these little colored dots, and essentially all the colored dots have about the same number in an individual nucleus. Here's one that's obviously very deranged. We have look at all these green signals compared to the yellow signals and blue signals, et cetera. So this one is an obvious melanoma. And this one, a lot of these cells have 4 signals of everything, and this is tetraploidy. So this is actually a really difficult test to interpret. It's technically challenging because you have to see the chromosomes in the right plane of section. Because we're looking at a 2-dimensional presentation of a 3-dimensional object, and so some of the chromosomes are not going to be in the right plane. So it's a very difficult test to interpret. Now, more recently, Myriad Genetics has come out with their test called MyPath Melanoma, which is essentially a quantitative PCR test looking at a gene expression signature that differentiates nevi from melanoma. And what they do is they scrape off parts of the tumor off the slide, and they do quantitative PCR off an cDNA library from the RNA, and they looked at 23 differently expressed genes by PCR. Tumor differentiation genes, some inflammatory genes, and some housekeeping genes make up the bulk of the genes in this assay. And they had different signatures. Okay, so this is like the PRAME is one of the big ones in this one. This is heavily weighted in their test, and so PRAME expression was much more highly expressed in melanoma than in benign tumors. Now, unfortunately, just like any test, it's imperfect. So there's overlap between the benign and malignant tumors within this group. Now, this is their cutoff point. So they said anything above this cutoff, they would call melanoma, at least having a signature associated with melanoma. And anything below that cutoff point is more likely to be benign. But notice there's a tail on both sides. So it's imperfect. All right, so what about comparing FISH versus gene expression profile? Now, obviously, one of the limitations of all of these tests is that the gold standard of diagnosis is H&E. And H&E is obviously very subjective, just in microscopic interpretation. They have overall similar sensitivity and specificity, at least with the validation stats studied. I would say the advantages of FISH, you can look at really specific subpopulations. So for example, if you have a melanoma rising in a nevus. I also think FISH tends to be better in the Spitzoid lesions. What about gene expression profiling? When is that more advantageous? Or what are the advantages of that? Well, it's less subjective because you don't have to count all these little colored dots in a nucleus, and so you get a computerized answer, and it's less subjective in terms of the interpretation. You don't have issues with tetraploidy or partially visualized nuclei. I think that gene expression profile is better on the thinner lesions and the question of whether it's a severely dysplastic nevus or a melanoma. I think that's when this test performs better. Both have adjunctive roles. Positive results are useful. Negative or indeterminate results are less useful. Again, remember, anytime you have one of these tests, how they perform on indeterminate lesions is not as good as how they're going to perform on the validation sets. So the sensitivity and specificity is always a little less good on the lesions you want it to do the test on. All right, now recently we've discovered that kinase fusions are really common in Spitz tumors, including a variety of different kinases like ROS, ALK, NTRK, et cetera. And unfortunately, they're not specific to the biology of the tumor. So you can see the same fusions in Spitz nevi, atypical Spitz tumor, and Spitzoid melanomas. However, these might actually be attractive therapeutic targets down the road as we develop assays to identify which one of these Spitzoid melanomas have these fusion genes. So ALK-fused tumors tend to be polypoid and spindled, like Dr. Ko showed. NTRK ones tend to have more cheminobodies, and ones with BRAF fusions tend to have much more nuclear pleomorphism. And again, these may be future therapeutic targets. Here's an ALK-fused lesion with a prominent spindle cell morphology that we see here. And you can do ALK immunostains to assess for whether or not they have that fusion. This tumor, I don't know what the fusion status is, but it's got lots of pleomorphism, so this Spitz tumor might be one that harbors a BRAF fusion. All right, so we're going to move away from melanocytic lesions. We're going to talk briefly about cytogenetic abnormalities in soft tissue tumors. And as you may know, translocations are the most common cytogenetic abnormality in the world of sarcomas. And what we usually do is we do FISH, and the common approach is to do break-apart FISH probes. So if the chromosome is not rearranged, you see the red and green signal next to each other. If it is involved in translocation, you see separation of those signals. So here's a challenging case. This is one I had at IU actually before I joined the clinic. A woman presented with a lesion on the palm. They thought it was a pyogenic granuloma. Okay. I didn't think it looked like a pyogenic granuloma. We see these sheets of these very sort of round cells, and I noticed it did have fairly prominent capillaries in it. And then so, of course, I did immunostains to work it up, and it's negative for CK20, so not a Merkel cell, negative for synaptophysin, negative for cytokeratin, not some adnexal tumor, not a melanoma, not a glomus tumor, and not a lymphoma. However, when you then sort of take a step back and think we have this small round blue cell tumor, we did CD99 stains, diffusely positive, did a genetic test for EWSR rearrangement, This is the cutaneous Ewing sarcoma. All right, another case, a 12-year-old boy with a thumb lesion. So here we have another thumb lesion here, and so here we have this population of cells, sort of epithelioid to spindled, a few multinucleated cells, and notice these nests are separated by fibroseptations. Immunostains positive for melanocytic markers, but this tumor also had an EWSR rearrangement 5 fish, and this is the clear cell sarcoma. Okay, so clear cell sarcomas can be a potential mimic for melanoma, except they tend to occur in young adults, usually the lower extremity, but occasionally they can occur in superficial lesions like we had this one. And these are aggressive tumors that you need to be able to recognize. Cytogenetics, they tend to have EWSR1 gene fusions. Interestingly enough, it's the same gene fusion that you can see in angiomatoid fibrous histiocytoma, and they lack BRAF mutations. Now I'm going to finish with vascular tumors in the setting of breast cancer. Now in the old days, we saw this, Stewart-Treves syndrome. This was originally described in 1948, in which Dr. Stewart and Dr. Treves described 6 patients with angiosarcoma in the setting of radical mastectomy. And these patients would develop extensive edema of the chest wall or ipsilateral arm. And in general, the mean onset of this angiosarcoma was about 10 years after they completed their therapy. And this is actually a picture from Laura Pincus from UCSF and a little case report she had in New England Journal of Medicine. But you can see this is what it would look like. There's numerous violations, erythematous papules, plaques, nodules on the edematous extremity. Now, we don't do that type of therapy anymore, at least it's extraordinarily rare, and we now do conservative therapy because we do lumpectomy with adjuvant radiation therapy. And why do we do that? Because it has better treatment for the patient because it has much less morbidity and associated with equivalent outcomes as radical mastectomy. However, now we have these other types of vascular lesions in this clinical setting, these things called atypical vascular lesion and post-radiation angiosarcoma. Both of these lesions tend to arise in the radiation field in, interestingly enough, a very short latency period, on average 3 to 5 years. After they complete radiation therapy, patients might start developing these lesions. Here's an example of an atypical vascular lesion. Here we have these dilated vascular spaces lined by maybe slightly hyperchromatic but not overtly atypical melanocytes. This one sort of looks like a lymphangioma. This one looks a bit like a hobnail hemangioma, where you have these vascular spaces lined by these hobnailing cells. They get a little bit compressed as you go down into the dermis, and there's a scant lymphocytic infiltrate associated with it. So there's 2 sort of broad histologic types of AVL. Now, post-radiation angiosarcomas can really span a spectrum of appearances. Here we have sort of a well-differentiated angiosarcoma. Here we have these back-to-back vessels. Here's an epithelioid one. Here's one that's sort of spindled and hyalinized. So we should be able to tell those apart by histology and clinical, right? I mean, that's the whole goal here. So AVLs tend to present as pink papules, and angiosarcomas look violaceous nodules, plaques. AVLs tend to be circumscribed and confined to the dermis, whereas angiosarcomas tend to be big infiltrative tumors. They both can have some architectural complexity to the vessels, so that feature doesn't help so much. If you do see multiple endothelial layering, it's an angiosarcoma. Okay? If you see hyperchromasia, doesn't help, but if you see lots of nuclear atypia, that really helps make the diagnosis pretty easy. And if you see mitotic activity, you're dealing with an angiosarcoma, not an AVL. All right. So you have that table, you go back to your microscope, and you can make these diagnoses. Okay. So unfortunately, it's not that easy. This was a paper out of Stanford a number of years ago now, but I think it really illustrates the lesson. They had 11 cases of AVL, now on biopsy, AVL, and when they went to the re-excision specimen, 5 of them, or almost half, were reclassified as angiosarcoma. Okay, so they had the same type of information we would have had, and yet, given that information, given histologic features, they still missed it almost half the time. All right, now, interestingly enough, we have some new insights into the pathogenesis of these post-radiation and also lymphedema-associated angiosarcoma. This first started out of a group from Germany when they noted MYC amplification, the oncogene MYC amplification in 55% of angiosarcoma secondary to either radiation or lymphedema. And they noted that MYC amplification was not seen in primary cutaneous angiosarcomas, the angiosarcomas that old people get on the head and neck. You don't see MYC amplification in that setting. And following up this, the folks at Memorial, led by Christina Antonescu, found MYC amplification actually in 100% of post-radiation angiosarcomas, and interestingly, in none of their radiation-associated atypical vascular lesions. And Tony Fernandez actually published a really nice paper a number of years ago now in Journal of Cutaneous Pathology, and we looked at a series of post-radiation angiosarcomas and post-radiation atypical vascular lesions, both by immunohistochemistry and by FISH. And all 8 cases of the angiosarcoma showed marked FISH amplification, or marked MYC amplification by FISH, lots and lots of red signals in this nucleus. And none of the cases of AVL. Notice that we have the reference probe here in the green and the MYC probe in the red, and there's the same number of signals in each one of these nuclei, so it's not amplified. And similarly, Thomas Menzel and colleagues out of Germany, in a somewhat larger series, they looked at MYC amplification, and all of their cases of post-radiation angiosarcomas were MYC amplified, and none of their cases of atypical vascular lesions were amplified. Now, what often happens, and we saw this essentially with Dr. Koh's talk too, we have a genetic finding, and then we can also use that genetic information and do immunohistochemistry on it as well, as a surrogate marker. So in our study, all of the cases of angiosarcoma were positive for MYC by immunohistochemistry, and almost all of the tumors by Thomas Menzel's group were positive as well. None of our cases of AVL were positive, and in Thomas Menzel's, only one was focally positive. Now, a word of caution, MYC immunostains are very tricky. They need to be titrated very carefully. They can have high background. AVLs are rarely focally positive. If there's any uncertainty, do the molecular test. FISH is the gold standard. All right, a 32-year-old man with a lesion on the trunk started getting bigger. And here what we have is the sort of blander spindled cells here, and this abrupt transition to this herringbone hyperchromatic spindled cells that we see here, mitotic activity, much more nuclear atypia. And this is a case of a Fibrosarcomatous DFSP. Now, we know Fibrosarcomatous DFSP can be aggressive, unlike conventional DFSP, with metastatic rates of up to 33%, depending on the series you read. And certainly if you get wide excision and negative margins, that helps decrease the risk of local recurrence and maybe metastasis. Now, we don't use molecular very often as a diagnostic tool for dermatofibrosarcoma protuberans, but you probably all know that this does have a recurring translocation involving the platelet-derived growth factor beta hooked up to the collagen type 1 promoter, this fusion gene. So FISH can be a diagnostic tool in selected cases, and occasionally we have done it. However, really this is a way to inform you to think about the tumor clinically, because PGF-beta receptor activity can be blocked by tyrosine kinase inhibitors like imatinib mesylate. And in fact, there was a phase 2 clinical study that first showed dramatic response of patients with essentially inoperable DFSP to treatment with imatinib mesylate. This patient has not had surgery yet. This tumor essentially melted away with chemotherapy. And more recently, a group out of Poland and Belgium published a fairly interesting study on long-term results of treatment of advanced DFSP with imatinib mesylate, and looking also in cases that had fibrosarcomatous transformation. They had 31 cases with either advanced or inoperable or metastatic, either DFSP or fibrosarcomatous DFSP. Metastases tend to occur in lungs, soft tissue lymph nodes. They had at least a partial response in 68%, and some of the patients ended up getting sort of stable disease, and some of course progressed through the treatment, because as we know, tyrosine kinase inhibitors, you can develop drug resistance. And progression-free survival was still pretty good considering how advanced these tumors were, and overall survival, close to 70%. And here's an example. This is a rather dramatic photo here. So this patient had a response to imatinib. This is before therapy, obviously. Okay, and then after 3 months, the patient then had radical resection and no recurrent disease, 5 years follow-up. So the drug allowed them to perform a surgery that would probably be impossible, at least at the outset. And in this group, and patients that had resection, 13 out of the 16 had partial response, and of those 13, after they had a combination of drug therapy and excision, 9 of them did not have evidence of recurrence, at least during their follow-up period. So this is not exactly using the molecular understanding as a diagnostic tool, but it is using the molecular understanding as a way to turn around and treat the patient. So molecular testing allows for more accurate diagnosis. And again, knowledge of the tumor genetics will provide you a rationale for targeted therapy.